histological analysis. Due to our high suspicion of fungal infection, we gave intracameral voriconazole and moxifloxacin injections, and to our surprise, there was a dramatic reduction in size of the lesion on post-op day 1. But the KOH mount did not show any fungal hyphae. 5 days later, there was growth of Aspergillus on SDA agar, and LPCB mount confirmed Aspergillus fumigatus. Bacterial cultures and cytology were normal, so left eye Aspergillus iris granuloma diagnosis was made, and patient was started on oral antifungals and topical moxidexa to control the inflammation. Since there was a dramatic response with 1 injection, we decided to repeat a second injection 1 week later, and over the next 3 months, we can see that the lesion completely resolved, the pupil became round, the vision was 6-6, and the eye was quiet. The medications were slowly tapered and stopped. But 10 days after stopping the medications, there was a recurrence. So due to previously documented response to intracameral vozole, we gave 2 more injections at weekly interval to reduce the size of the lesion and planned for a sectoral iridectomy this time to remove any residual fungal hyphae in the iris stroma. But the histopath and culture sensitivity were inconclusive. So we gave a 6 weeks course of oral antifungals and topical medications, and at 6 weeks, the vision was 6-6, eye was quiet, and patient was asymptomatic. But to our dismay, 2 weeks later, the lesion recurred. This time, we thought of reconsidering our diagnosis. So we planned for a lesion plus localized anterior capsular tissue excision and sent samples for aerobic and anaerobic culture, fungal culture, and histopath. And to our surprise, we found Propionibacterium acne growing in the anaerobic media, which was sensitive to Vancomycin and Moxi. Now, one might think, why did we not consider P. acne to begin with? This is because P. acne usually presents with either white plaques or a chronic indolent granulomatous type of inflammation, and this was not the case in our patient at presentation. Now we were in a dilemma. The patient's vision is 6-6. He is not ready to undergo aggressive surgery like PPV and IOL or bag removal. So we decided to do an AC wash with vancomycin this time along with moxifloxacin. And at 1 week after the wash, there was no residual lesion. We slowly tapered and have maintained the patient on topical moxidexa drops once a day. Over 3 months and 6 months, we can see there is no residual lesion, there is no recurrence. Vision is 6-6, IOP is normal, and the patient is on monthly follow-up. So what did we learn? In addition to iris malignancies, intraocular infections too can rarely present as a recurrent iris granuloma, and Propionibacterium in post-op patients and Aspergillus in immunocompromised patients can have this type of an appearance, and the possibility of a polymicrobial infection should be considered in all these patients right from the beginning, and the investigations and management is to be done accordingly. These are my references. Thank you very much.
Very nice presentation.
Thank you.
Dr. Mittal, how do you come with your diagnosis? Is it based on clinical diagnosis? When you have the differential, like fungal, you suspect a fungal granuloma?
Sir, the first time when we suspected fungal, it was based on clinical features and history. Patient is a diabetic, had a recent UTI, had a IV cannula for 7 days in situ, and then comes with a fluffy mass-like lesion, which is usually reported as a fungal ball elsewhere in the body. So we did a literature search, and we found that Aspergillus iris granuloma has been isolatedly reported from different parts of the world, and it can present like this. Whenever there's an endogenous seeding, it comes and resides on very specific part of the iris. If it was a post-op fungal seeding, there might have been some port infiltrates. The eye would have been more symptomatic as compared to how our patient presented. So our first differential was a fungal granuloma, and then the AC tab proved Aspergillus, so our treatment was dictated according to the AC tab reports.
What was the duration of the treatment?
So the first time when the patient presented, we treated for 3 months till we saw complete resolution, and we gave antifungals 2 weeks beyond the point of resolution clinically. He had a recurrence 10 days later. That time we treated for 6 weeks because we thought we had done a sectoral iridectomy and we would have removed any residual fungal hyphae load. So that time we treated for 6 weeks. But then 2 weeks later he came again with the same recurrence. So after that we did an AC wash, and for 3 months the patient had slow tapering of topical moxidexa. We did not give antifungal the third time, and now it's been 6 months. He's on once a day moxidexa and is asymptomatic.
So how can you explain on, sorry, I just skipped.
Thank you so much.
Okay.
Second presenter. So our second presenter is Dr. Ajay Krishnamurthy A challenge in diagnosis and management, 3 cases of rare sinonasal malignancies.
Yeah, good afternoon, everybody. I thank you for the opportunity. I'd like to present 3 cases of rare sinonasal malignancies that we came across in our practice. Why am I presenting this? Because they are very rare and aggressive because of their difficult to reach locations and rapid progression of the disease. So the first case that I'd like to talk about is a sinonasal undifferentiated carcinoma. Here we came across a 58-year-old male patient who had progressively increasing swelling and blurring of vision in the right eye for about 3 months. On examination, his visual acuity was low, about 618, proptosis, palpable mass in the orbit, which was in the superior nasal and restriction of movements. On imaging, we found a soft tissue mass which was in the superior nasal orbit, which eroding into the ethmoid and the frontal sinus, but not extending intracranially. So we did an endonasal biopsy, and on biopsy, on low power magnification, we found tumor cells in sheaths, nests, and lobules, and on high power, it showed large nucleus tumor cells with scanty neoplasm and brisk mitosis. On immunohistochemistry, pancytokeratin, AE1 and AE3 were positive, and also the CK7 was positive. So it was considered as SNUC, and he was subjected to right eye excision biopsy of the orbit. We did a Lynch incision. We did a Lynch incision just medial to the middle canthus, and also endoscopic approach was utilized, and the tumor was completely resected. At the end of 1 year, there was no recurrence post chemo and radiotherapy. What are the key things? Since it's an aggressive disease and sometimes extension intracranially, then it becomes non-resectable and it will be subjected only to radio and chemotherapy. And whenever we remove it, complete removal is the key to its eradication. The second case I'd like to discuss is about a maxillary alveolar rhabdomyosarcoma. This was a 38-year-old female who presented with us with nasal stuffiness and diplopia on down gaze. On imaging, there was a soft tissue mass which was occupying the entire maxilla, right nasal cavity, as well as the ethmoid, anterior and the posterior ethmoid sinus, and which was impinging from the floor of the orbit. And she also underwent endoscopic biopsy, where there were sheets of small round blue cells were noted, and she was having myogen positivity as well as Desmond cytoplasmic positivity. So thereby reducing it to be an alveolar rhabdomyosarcoma. She underwent a right excision biopsy. We did a transconjunctival orbitotomy, floor, as well as the endoscopic approach. In the intraoperative frozen section analysis, when we did a frozen section, it came out to be negative for malignancy, which is very surprising when the tumor of such magnitude is present. That is because of the heterogeneity of the rhabdomyosarcoma. Unless the entire tumor is examined, we can come across these non-conformational or sometimes negative for malignancy things. She underwent radiotherapy, and she's yet to come for follow-up at 6 months' time. So key points in this is, yes, we usually see it in younger age group where alveolar is much more common, whereas when we see younger adults, children come with embryonal type, whereas the younger adults will have an alveolar type carcinoma. The last case is a lacrimal sac squamous cell carcinoma. A 52-year-old male presented with excessive watering in the right eye, and on examination he had a palpable mass at the medial canthus. Well, on endoscopic examination he had a mass in the right nasal cavity. We did imaging. We found a soft tissue which was in the lacrimal sac, expanding the bony volume as well as encroaching into the orbit, extending up to the optic nerve. And on endoscopic biopsy, histopathological section, we visualized a residual lacrimal duct with SCC growing with desmosomes around it. So the key point would be less than 15% of such cases are actually diagnosed in the first 2 months. Most of them are missed and undergo repeated DCRs and DCTs till the surgery, the diagnosis is confirmed. Thank you.
Your third case is sinonasal malignancy, or primarily it is a lacrimal sac malignancy. So it is not, I think, it is not a sinonasal malignancy,
Okay.
or the malignancy which is arising from the neighboring structure and leading to the secondary orbital malignancy.
Yes, I agree with you, sir. I agree with
That's
you.
why your two cases are the cyanonasal malignancy, but third one is the lacrimal sac malignancy.
Yes, sir, I admit. Okay.
The next presenter is
Thank you.
Dr. Kavita. No. Dr. Bhavani, and she will talk on the choroidal metastasis leading to sudden vision loss in rectal adenocarcinoma, a case study.
So, good afternoon, everyone. I would be presenting an interesting case of choroidal metastasis. So, we all know that choroidal metastasis is an uncommon but significant manifestation of systemic malignancies occurring in approximately 2 to 9% of the patient with metastatic cancer. The ocular metastases are predominantly located in the choroid due to its rich vascular supply, and the gastrointestinal cancers, which are rare, including the rectal adenocarcinoma, can spread to the choroid. So the purpose is to report a case of sudden decrease of vision in a patient of rectal adenocarcinoma, highlighting the rare occurrence of choroidal metastasis post initial successful treatment of the carcinoma. So 34-year-old male present with a history of rectal adenocarcinoma, initially treated with surgical resection and local radiation, presented with sudden painless decrease of vision in his left eye. His oncologic history included a disease-free interval of 6 months followed by local recurrence requiring additional radiation therapy 3 months prior to the presentation. His initial histopathological examination of original rectal lesion confirmed the presence of moderately differentiated adenocarcinoma. On ocular examination, his visual acuity was hand movement in the left eye. Anterior segment examination was unremarkable. On fundus examination, the media was a bit hazy due to vitreous hemorrhage, but we could see the large choroidal mass in the inferonasal quadrant with hemorrhagic spots on the surface, which was obscuring the view of disc and macula, and there was surrounding little bit exudative retinal detachment as well. The other eye examination was completely within normal limits. On ultrasound B scan, we noted an elevated dome-shaped choroidal mass approximately 15 by 12 mm, which had heterogeneous echoes with medium to high internal reflectivity. There was no evidence of calcification or acoustic hollowing, and surrounding minimal SRF was present. We suggested patient for the MRI, and it also concluded with the finding of 15 by 17 by 17 mm tumor in the posterior pole. The whole body PET scan was done by the oncologist, and they confirmed the metastatic spread in and beyond the eye. There was a spread to the CNS as well as the lungs. They started him on the systemic chemotherapy with injection oxaliplatin and tablet capecitabine was initiated, but unfortunately patient did not respond and patient died within 10 days of starting the treatment. So to discuss with, ocular metastasis is most commonly seen in breast carcinoma followed by lung carcinoma, but rarely it can arise from gastrointestinal tract, prostate, kidney and skin as well. The ocular metastasis from rectal adenocarcinoma is rare, and when present it typically occurs late in the disease course and is considered a poor prognostic sign as in our patient. So to differential diagnosis include for such malignancy includes a choroidal melanoma, inflammatory lesion, vascular tumor, which necessitates imaging and confirmation. So the management of choroidal metastasis depends on the systemic status of the patient, along with number of choroidal tumors, its location and the laterality. Observation is preferred in patients with poor systemic status. Systemic chemotherapy, immunotherapy, hormone therapy or whole eye radiotherapy if the metastases are multifocal and bilateral. The plaque radiotherapy, transpupillary radiotherapy or photodynamic therapy for the solitary metastasis. Sometimes enucleation is required for blind painful eye and to prevent the spread. And rarely the intravitreal anti-VEGF is also advisable nowadays to prevent the secondary exudative retinal detachment and to reduce the vascularity of the tumor. So to conclude, this case highlights the importance of recognizing ocular metastasis as a potential sign of cancer recurrence. So effective control of these lesions is imperative, and given the rarity of colorectal cancer metastasizing to eye, This case emphasizes the need for vigilance in cancer patients presenting with sudden visual changes. These are my references. Thank you.
Dr. Bhavani, that was a quite interesting case. With very short disease free of only 6 months,
Yeah.
and the recurrence you see, and then there's sudden loss or diminution of vision with such a large choroidal mass is really rare. Could you think of any other differentials in such scenario, like given the age of 58 years?
Yeah, of course, if the PET scan could not have confirmed the diagnosis of other systemic lesions, we would have planned for the biopsy to confirm the diagnosis of the lesion. But unfortunately, the PET scan came positive, and it suggested the metastasis even to the CNS, lungs, and few cells in the liver as well.
So the systemic uptake value of all the lesion were same with the primary lesion on PET CT scan.
For the lungs and CNS, it was same.
Okay.
And unfortunately, the patient was diagnosed with the cancer just 1.5 years before all these things, and he was disease-free, completely disease-free 6 months. And then again, he was diagnosed with local recurrence, but at that time also they did the PET scan, but there was no systemic metastasis. So systemic metastasis was like quite fast within 3 months.
Okay, thank you.
Thank you.
Next presenter is Dr. Kavita. She will talk on retinoblastoma with staphyloma, clinico-radiological profile and outcome. Dr. Kavita.
Good afternoon, everyone. Today I am going to present retinoblastoma with staphyloma, clinico-radiological profile and outcome. So RB is most common primary intraocular malignancy of childhood. It accounts for 3% cases of all childhood cancers. Staphyloma is defined as outpouching of the sclera with its curvature of radius being smaller than the curvature of the surrounding eyeball. Myopia, end-stage glaucoma, choroidal melanoma, trauma are associated with staphyloma. To date, no studies have specifically focused on the clinical outcome and treatment implications of staphyloma in RB patients. So we speculated that the presence of staphyloma might influence the prognosis and the likelihood of globe salvage, given the potential complications such as scleral thinning and increased risk of extraocular tumor spread. So few clinical features which are associated with high risk feature on histopathology, such as longer lag period, hyphema, pseudohypopyon, staphyloma, orbital cellulitis. These are the high risk features like post-laminar optic nerve infiltration, involvement of the optic nerve transaction limit, extrascleral tumor extension, choroidal invasion. These are universally accepted by the ocular and pediatric oncologists, while anterior chamber invasion and ciliary body invasion were considered as high risk feature by few ocular oncologists or pediatric oncologists. So our aim was to study clinico-radiological profile and outcomes of retinoblastoma eyes with staphyloma. This is a retrospective case series of 13 patients from January 2019 to May 2024 with ciliary staphyloma clinically or having a scleral staphyloma on imaging, and who had taken complete treatment. Those who refused for the treatment, did not complete the treatment, or having extraocular involvement were excluded from the study. The demographic details, clinical, radiological and histopathological data were analyzed, and treatment outcomes were measured in the form of globe salvage, event-free survival, recurrence and death. So we divided the staphyloma in 3 categories: ciliary, pre-equatorial and posterior. So our total 13 number of patients with mean age at presentation was 16.5 months. Mean duration of symptom was 17.4 weeks, which was lesser in group E eyes as compared to group D. 9 patients had group E retinoblastoma and 4 had group D, while white reflex has most common presenting symptom. So in group E eye, 1 eye had ciliary staphyloma and 8 eyes had posterior staphyloma, while in group D, 1 had ciliary, 2 had preequatorial and 1 had posterior staphyloma. 3 eyes were undergone primary enucleation, 6 were undergone secondary enucleation and 1 globe was salvaged. This is group E RB having posterior staphyloma on imaging. So, in ciliary staphyloma, one patient had PT3 staging on 8th AJCC PTNM. Anterior staphyloma, one globe was salvaged, another one had PT1. And in posterior staphyloma, one patient had anterior chamber invasion under PT2 and two patients had PT3. In posterior staphyloma, one patient was died because of CNS metastasis and one patient had recurrence 6 months after enucleation. This is the group D, uncontrolled group D RB, who had recurrence in inferior orbit 6 months after enucleation. It was treated with EBRT and adjuvant chemo. Now he is doing well, 1 year follow-up. So there are some clinical features at presentation which could predict high-risk pathology such as staphyloma, orbital cellulitis, glaucoma, and UVS, NVI. This may help oncologists and ophthalmologists in deciding the need for prophylactic chemotherapy in the absence of histopathology report. To summarize, posterior staphyloma was more common in group E, while pre-equatorial in group D. High-risk features were more common in posterior staphyloma, and pre-equatorial staphyloma has good prognosis, as out of 2 eyes, one globe was salvaged and another one had recurrence. To conclude, posterior staphyloma exhibits more high-risk feature on histopathology. This necessitates more aggressive and early intervention. Thank you.
Now, how do you compare about without staphyloma and staphyloma? Because this is just about staphyloma.
This is staphyloma.
Yeah, so any cases of anterior staphyloma which were there? No.
No, sir. Only ciliary staphyloma, which 4 to 5 mm from the limbus, or scleral staphyloma on imaging, like posterior staphyloma between the optic nerve and the lateral rectus muscle, or anywhere else.
So, would you give a definitive inference about doing this study? That staphyloma is having an impact on the recurrence part or any prognosis?
Sir, there is only one study which suggests that
about your study, what you have inferred. There are studies, but what is your inference in this study?
Yes, sir.
What something different or something?
Sir, in case of staphyloma, we found that out of 13, only 3 patients had high-risk feature on histopathology. Out of these 3, one had choroidal invasion, another one had optic nerve and choroidal invasion, and one patient had scleral invasion on histopathology. So we could not say because of staphyloma whether there is scleral involvement.
No correlation between the staphyloma and the recurrence part or the high-risk
features.
Okay, right. Thank you.
Okay, thank you, sir. Local recurrence and mets.
Recurrence and orbital extension.
Yes, thank you.
Now, next presenter is Dr. Pragya Bhattacharjee. She will talk on beware the deceptive tumor, unveiling the wolf in sheep's clothing.
Good afternoon, judges and this August gathering. I am Dr. Pragya Bhattacharjee, a junior resident from AIO Hyderabad. And before I start this presentation, what if I told you that sometimes even a harmless looking mask can hide a more dangerous truth? And therefore, I titled my presentation with a caution that beware the deceptive tumor, unveiling the wolf in sheep's clothing. No disclosures. Now, there are 2 main characters of my presentation. First is the harmless looking sheep. I call it harmless because initially we thought it was a sebaceous cyst, but as the story unfolded, this sheep turned out to be the wolf, an unsuspecting but later histopathologically confirmed tumor which was disguising itself very innocuously. Now, our patient was a 73-year-old female who presented with a mass in the left nasojugal groove just below the medial canthus, progressively increasing in size over 2 years, with a size of 20 into 15 millimeters on presentation, dome-shaped with a hyperpigmented nodule at the top, cystic to firm in consistency, non-tender with an adherent overlying skin, but free from the underlying tissue. She also gives a history of incision and drainage 6 months ago. So on the basis of the clinical features and the history of an IND, we thought that maybe it's a sebaceous cyst. So nonetheless, it was completely excised and the mass was sent for a histopathological examination for confirmation, and she was advised for a regular follow-up. But when we received the reports, we were a little unconvinced with the diagnosis because it stated that it was a biphasic tumor, most likely to be an orbital pleomorphic adenoma. Now, me being a postgraduate trainee, I always thought that the mass is suspected to be an orbital PMA if it arises from the superlateral quadrant of the orbit. So either maybe it was a misdiagnosis or maybe it was an ectopic pleomorphic adenoma. To confirm the diagnosis, again we repeated a histopathological examination and also requested for an immunohistochemistry. And again this time it was not the sheep that we were expecting, but the wolf that I did not know existed. The histopath report stated that there were tubules and ducts lined by cuboidal and myoepithelial cells lying in a chondromyxoid stroma, and also along with it there was normal subcutaneous tissues. On other sections, we could also see chondroid differentiation of the myxoid stroma. It was immunoreactive to pancytokeratin and to cytokeratin 7, which were highlighting the ductal epithelial cells, and also to P63 highlighting the myoepithelial cells. Now, all of these findings were indicated towards a mixed kind of a tumor, but not exactly a pleomorphic adenoma. We had epithelial components which was well organized into ducts and tubules. We had decapitation secretion. The myxoid stroma was more cartilaginous than gelatinous, and there was also adjacent normal subcutaneous tissue, all of which indicated towards not a pleomorphic adenoma, but its cutaneous analog that we known as chondroid syringoma. Now, these are rare cutaneous mixed tumors with a reported incidence of 0.01 to 0.098% of all primary skin tumors, most commonly seen in the Middle Ages to the elderly males in the head and neck region. Our case is atypical and unique not only in its demographic presentation, but also in its presentation as a cystic to firm mass with overlying hyperpigmented skin. As far as literature goes, there are 28 reported cases, and ours would become the 29th case, and the first case presenting in the nasojugal region with hyperpigmentation of the overlying skin. Therefore, to conclude with its clinical implication, chondroid syringomas are rare tumors to present to us, and hence very likely to be overlooked and misdiagnosed. Preoperative investigations make it indistinguishable from its differentials like sebaceous cysts and other neck cell tumors. Therefore, histopath examination becomes gold standard. Given its possibility to recur, become malignant, and metastasize, having prior knowledge would prove to be crucial. And with this, I conclude. These are my references. Thank you very much for your patient hearing.
Yeah.
Thank you, sir.
Nice rare case presentation. Now next presenter is Dr. Himika Gupta, and she will talk on 3 hits and miss lesson learned in retinoblastoma diagnosis.
Good afternoon, everyone, respected judges. I'm an ocular oncologist based out of Mumbai, and today we'll be looking at 3 hits and a miss that we learnt over the 8-year period of RB work that we've done. So out of 47 patients which were referred as retinoblastoma, 9 were unsure, and out of that 2 were PHPV, 3 were ophthalmos, and 4 were, well, very different, we thought. And we are going to look into these 4 X files. So the first was a 1-month-old, 1 kg child referred from the NICU with this small mass during ROP screening, which looked like a retinal astrocytoma or a hematoma. So we sent her for MRI screening, and there were subepidermal nodules, which was suggestive of tuberous sclerosis. So that was our diagnosis. We decided to wait and watch. The next EUA, the tumor grew, the child also grew, and there was subretinal fluid. Looked like a group D retinoblastoma. So we were quite confused, but because the tumor grew, we decided after tumor board, let's treat it like RB, and we gave her the protocol based management, chemo. She did not tolerate it too well. She had multiple trips to the ICU, but yeah, somehow she made through. And finally, in October 24, the tumor was totally cured. Her genetics turned out to be negative for TSC, negative for RB, but 1 VUS. So here we dealt with this first case, which looked like a tuberous sclerosis, but finally turned out to be retinoblastoma. Case 2 was a 4-year-old child who presented with a sudden onset redness, watering, decreased vision. There was almost a hyphema and a corneal melt. Well, this case had an anterior staphyloma in the inferior part. And there was no other history suggestive of leukocoria or anything. B-scan showed the lens which was subluxated into the vitreous, a vitreous hemorrhage, no tumor. And our working diagnosis was endophthalmitis, orbital cellulitis, or perhaps a mascarade. So we treated him with antibiotics and IV steroids and posted him for an EUA. And what we found was on the better eye, on the other side, if you can see, there was a small 1.5 dd tumor. So we were actually dealing with a case of bilateral retinoblastoma presenting as a mascarade. He underwent enucleation and implant for a painful blind eye with suspected tumor. We found tumor in his eye. It was RB, and he was treated as per the protocol. The third case was a 9-month-old who presented with squint at 3 months. He was reassured. Then he got leukocoria/yellowish reflex. He was again reassured by the pediatrician. And then when the parents changed the pediatrician, he was evaluated and diagnosed to have Coats disease. He was referred to us for an EUA just in case. And what we found was shocking. Bilateral retinoblastoma, one eye group E, other eye group D. Systemic workup, negative. Genetic testing, negative. So now we were shocked. And the parents were relieved. They said, no, this is not retinoblastoma. Our primary doctor told us this is not RB. So we were more shocked. We said, okay, now what do? We treated him based on protocol and repeated the genetic testing. First time it was the MLPA, multiplex ligation analysis. And now we did the NGS full sequencing, slightly more costly, but we had the answers. It was retinoblastoma. The last case was a 4-year-old who presented with leukocoria elsewhere, had a retinal detachment documented on B-scan, no tumor, reassured, sent home, came back after almost 2 years with this kind of a orbital mass. The imaging showed an orbital tumor extending from the eye into the orbit, but not beyond that into the CNS, and the other eye was normal even on EUA. So he was diagnosed to have an orbital retinoblastoma. So AJC staging was T4B N0M0. He underwent protocol-based management, but the pathology showed sheets and cords. No obvious, there were round cells, but not typical of retinoblastoma. There was bony tissue. I had not taken out any bone in this exenteration. So the pathologist said, is this rhabdomyosarcoma? But we went back to the history, there was nothing suggestive of that. Then there was a lot of push and pull amongst various pathologists, lot of stainings were done. And finally it was found that the LIN28 was focally intense, which is more for mesenchymal and medulloepithelioma-like cells. So the final diagnosis in this case was a malignant teratoid medulloepithelioma. And here I would like to acknowledge Dr. Kostomule, who helped us to come back to the final diagnosis. And finally, we treated him. The management was almost the same, so that part was good for us. So to conclude, we realized that, especially with these 4 cases, that examination under anesthesia, primary and serial follow-up, is a good idea, especially under a trained ocular oncologist setup. Okay? And wait and watch can also be an option. Sometimes it helps us to conclude a lot of things. Radiology alone may not be always helpful, and whenever possible, histopathology helps to seal the diagnosis. Thank you so much for your patient listening. We have this annual retinoblastoma event, and here the kids are getting prizes. Thank you.
Yeah, thank you, Dr. Hemika. That was quite an eye-opening cases you have got. Thank you.
Yeah, thank you.
Yes. Next is Dr. Priyanka, and she will present a study of microvascular density and VEGF in eyelid and ocular surface tumors.
Good afternoon, one and all. The topic of my study is to study the microvascular density and the expression of vascular endothelial growth factors in the eyelid and ocular surface tumors. The study was supported by institutional intramural research grant. What we know is that tumor growth
This slide is not running.
What we know is that tumor growth and metastasis rely on the vascular support. The vascular endothelial growth factor is a primary angiogenic factor in solid tumors,
The intratumoral microvascular density is an independent prognostic indicator. What is lacking here is the insight into the vascular pattern, which could guide us as anti-VEGF as a treatment modality. The hypothesis of my study was that islets and ocular surface tumors are associated with high vascular endothelial growth factors and increased microvascular density. The aim was to evaluate the factors involved in angiogenesis in cancerous lesions of ocular surface and islets using immunohistochemical techniques. To study the level of vascular endothelial growth factor and eyelid and ocular surface tumors, correlation between the microvascular density in VEGF, to establish a relationship between microvascular density and the features of tumors, which is clinical and histopathological. Also, to study the relationship of VEGF and the features of tumors, clinical and histopathological. There were cases enrolled over a 1-year period from the OPD as well as the oculoplastic clinic. These patients underwent total surgical resection, and after that histopathological examination was done. Relevant paraffin fixed blocks were taken out and immunohistochemical procedures were carried out for the evaluation of VEGF and microvascular density. The results observed were high vascular VEGF was noted in the malignant tumors, high microvascular density was reported in malignant tumors. It was interesting to note that the vascular VEGF expression within the tumors was highest in squamous cell variant as compared to the basal cell carcinoma and sebaceous gland carcinoma. Also, in tumors where we found high microvascular density, when we later look back, we also found that there was clinical aggressiveness also associated in the same set of patients. These are the immunohistochemistry slides. To conclude, our study showed vascular VEGF and microvascular density are significantly associated with malignant epidermal tumors. High tumor VEGF was seen in the squamous variant. High microvascular density is associated with clinical aggressiveness. Limitations were the small sample size. A longer duration of study is recommended for postoperative recurrences, and our studies lacked serum correlation. For innovation and advancement, institution of anti-VEGF therapy in squamous variant could be an option. Thank you.
Have you assessed the vascular endothelial growth factor through the serum of the patient or only through the biopsy?
Sir, actually in this study, we have only studied through the biopsy techniques, but we had also thought about this serum correlation.
Actually, the VEGF must be assessed through the blood sample serum, because the VEGFs are two types. One is the free flowing and another is a bound form. The free flowing VEGF, they are tumor marker. They are responsible for the metastasis, progression of the disease. So better go through the vascular endothelial, serum vascular endothelial growth factor.
Yes, sir. Thanks.
Next presenter is Dr. Rakhi Yadav. She will talk on pathological significance of ophthalmic foreign body. Though she is, I think, not a ratified member. You are you are ratified member. Here it is written. Okay. So you will be considered as a committee too.
Good afternoon, everyone. Topic for my presentation is pathological significance of ophthalmic foreign bodies. So, starting with the introduction, foreign bodies in eye and adnexa are important in ophthalmology, particularly in traumatic cases. To penetrate the eye and deeper structures, a foreign body must have sufficient momentum and energy. Therefore, most of the posterior segment foreign bodies are metal fragments, and vegetable matter such as wood may reach inner part of the eye and mostly confined to the anterior segment. Intraocular foreign bodies and various other foreign bodies in eye and adnexa in pathological significance can give a lot of information about the damage of the structures. So, coming to the materials and methods, it was a hospital-based retrospective laboratory study in a tertiary institute of Northeast India. Gross examinations were carried out in dissection microscope. Histopathological analysis was carried out with the H&E stain and polarizer. Special stains such as Pearl, GMS, PAS and Congo red were done to see the ancillary pathology. So in results, we found that we studied 16 pathological specimens with various foreign body were seen and they were classified. Hospital records were seen for clinical profile. radiological, ultrasound and other investigation to correlate the findings. 6 cases of iron foreign bodies were seen and they were documented. 1 case of copper foreign body was seen in intraocular specimen and thysical blind eye, which was confirmed by scanning electron microscope and energy dispersive spectroscopy. And 3 cases of vegetative foreign bodies were seen in orbit, lid and tissues. So 2 foreign bodies were detected in pathological specimen of sympathetic ophthalmia case, and urate crystal were documented in one of the conjunctival specimen. And one case had tripod glass full foreign body and was documented in the conjunctival specimen. A case of insect body and other cilia were documented in cohort. So summarizing the results, as we can see, out of 16 cases, 6 cases showed the iron foreign body, which was most common. These are a few slides of intraocular iron foreign body and demonstrating the lenticular changes. Other slides of insect being foreign body in lid tissues. These are all histopathological slides obtained. So pathology of eye trauma is of immense interest, as lot of changes in the eye and adnexa are unique from the pathology of the rest of the body, as understanding of the nature of activity during different intraocular foreign bodies are important for medical legal purpose, and determining its nature and call for an urgency of removal. Foreign body in cornea, anterior chamber, iris angle of anterior chamber, lens, ciliary body, vitreous, retina, choroid, optic nerve, etc. Have far-reaching impact on visual status and function of the eye. In our series, most of the iron foreign body which had larger sizes causes significant damage to the structure, and they are consistent with other studies as well. One of the vegetative foreign bodies showed adjoining aspergillus fungal infection in the tissue, which were also reported in the literature. In SO cases in pathology, 2 interesting cases showed foreign body, and both the eyes were thysical exciting eye, which were further enucleated. Subconjunctival urate crystals were seen in one non-traumatic eye of an elderly patient who came just for cataract surgery. And interesting isolated case of insect bodies, glass full tripod foreign body and cilia were seen, which were previously reported as well. To conclude, iron foreign body was the commonest in the study, and rarely foreign body can be seen in inciting eye of sympathetic ophthalmia, and pathological diagnosis are important for evidence-based medicine. These are my references. Thank you.
And how many patients you have iron foreign body?
Sir, 9 cases.
9 cases.
Sir.
And how many patients developed the thysical siderosis bulbi?
Sir, they 2 cases have been like we saw 2 cases.
What was the maximum duration of the retained intraocular foreign body?
It was after the trauma, like 8 or 9 months after
8 or 9
trauma.
months. Actually, the ferrous ion which dissociate and dispersed all the retina and ciliary body, that can lead to the mostly lead to the thysis bulbi and bulbi. Okay.
Thank you, sir.
One thing I have to say, your membership number is R29381. Here is clearly written that the membership number up to 2,28934 are ratified, and the number beyond that are not ratified and not eligible for the award category. So I think your number is not ratified, but you are saying that I am ratified member. Okay, the next presenter is Dr. Shomit Grover, and he will present awareness and knowledge of retinoblastoma among the nurses and allied health care workers.
Thank you, respected judges and the audience. My topic is like away from the OT, let's go to the public health aspect of the ocular oncology. It's a bit different topic from which we have seen right now in the session. So we all know that retinoblastoma is the most frequent primary intraocular tumor in the childhood, but the focus of our study, the presentation is the factors that contribute to the poor outcomes, including delay, includes delay in the presentation, lack of awareness, poor compliance, and absence of adequate healthcare facilities. And these things have been already been published, and the implication is that in the developed countries, where all these parameters are well taken care of, there is trend towards the globe and vision salvage, while in our developing country like India, the mortality rate and the later group E presentations are still a matter of concern. So purpose of our study was to assess the level of awareness and knowledge regarding RB among nurses and allied healthcare workforce in a tertiary care cancer hospital. So it was a cross-sectional hospital-based study which was conducted at National Cancer Institute, part of AIMS New Delhi, and databases of all the nurses and allied healthcare workers, including multitask staff, patient care coordinators, and patient care managers were obtained, and a questionnaire tool was constructed based on the review of literature to explore the study's aims and objective. The data was retrieved in encrypted form and all responses were kept anonymous. We analyzed the data on Strata software. Coming to the results, there were 411 participants who were involved in the study, out of which 196 were nurses working in the National Cancer Institute, and 215 were the allied healthcare workers. The response rates were 62% amongst the nurses participants and 80% in the allied healthcare workers. As far as the age and gender is concerned, majority of the participants were very much young, like 25 to 35 years, and almost equal female. Males were 239 and females were 172. As far as the educational qualification is concerned, all the nursing staff were categorized into a professional, like they have done their already, they were graduate in their nursing, and amongst the allied healthcare workers, almost all they have been graduated. Since the NCI is in the Jhajjar district, which covers the part of the rural Haryana, so majority of these our participants were from the rural background, according to their residence. So out of the study participant, when we asked about whether they know about RB, like were they aware about RB, so we found that only 28% of the we found that 28% of the nurses and 83% of the allied healthcare workers lacked awareness about the RB. So only 141 nurses said yes, and 37 allied healthcare workers said yes about that they know about RB. And when we ask about the source of information, those who have heard about the RB, they acquired this knowledge as a part of their study or work in the hospital, and only 2% of these respondents reported that mass or social media as a source of their information. When we asked to those who know, who mentioned yes about they know about RB, about the knowledge of sign and symptom, only like 117 nurses out of 141 and 4 out of 37 allied healthcare workers, they knew about the sign and symptom. And when asked about the leukocoria, which is the most common thing, which is the most common sign of RB presentation, around 140 out of 141 nurses, 105 they knew about leukocoria, and only 4 responded out of allied healthcare workers said yes. And knowledge about the treatment of RB, 114 nurses out of 141 they knew about the treatment. Only 1 out of 37 respondent said that I know about the treatment. So when we correlated the awareness and knowledge in participants who have the exposure in the field of eye care, we found that those who worked in an eye care setup previously were more likely to be familiar with RB presentation with the p-value significant. So the study concluded these provided the objective assessment of the level of knowledge and awareness, and we found that fortunately the nurses had sufficient awareness, but it was limited amongst the allied healthcare workers, underscoring the need of continuing medical education and training. And the finding from this study reveals the pressing need to increase knowledge among healthcare providers, because these are the first point of care among the hospital staff and the patient. And it also highlights the lack of insufficient IEC strategies, particularly the role of mass media for creating RB, and a nationwide awareness campaign to educate public and healthcare professionals about early signs of RB and its implication is required. These are my references. Thank you so much.
Thank you, Dr. Grover. Nice and very highly needed study, and I can say this is preliminary study that a multicentric project on retinoblastoma sanctioned by ICMR. You are the one of the investigator, yes, and second is myself.
Yes, sir. Thank you.
So here one question is, were they sensitized before, whatever your healthcare workers?
No, sir, they were not sensitized before, but after this study, we have made a kind of a IEC material for these care providers and the standees and the through the electronic media in the NCI, the leukocoria and other things have been displayed now.
Yeah, because initially when they are having an induction.
No, sir. This was like deliberately done. We didn't inducted them, and
Okay.
now we have displayed everywhere about the leukocoria and these
Right.
things.
So the main focus of ours is whoever is joining the institute or
Should-
tertiary accreditation center, this will be
yes.
given an induction course.
No,
And
sir.
there you should have all these diseases which are important.
It was a naive population, sir.
Okay.
Novice
Right,
population.
right.
Yes.
Thank you.
With this, I invite the next speaker, Dr. Bhumija Bhatt. She will be speaking on intravitreal chemotherapy for vitreous cysts in retinoblastomas, experience from Eastern India.
A very good afternoon to all. I am Bhumija Bhatt. I'm a fellow in oculoplasty at LV Prasad Eye Institute, Bhubaneswar campus. And I would like to present our experience of intravitreal chemotherapy for vitreous seedings in retinoblastoma and experience from Eastern India. So as we know, the targeted therapy in retinoblastoma is widely accepted as the current management tool with the aim of increasing the drug availability at the location of the tumor. Its effect is multiple folds higher compared to the systemic delivery of the chemotherapeutic agents that we use. The direct delivery of the chemotherapeutic agents into the vitreous cavity definitely helps to overcome the challenges and the accepted worldwide. So coming to the materials and methods of my study, it's a retrospective analysis of retinoblastoma patient who received intravitreal melphalan and raw topotecan for vitreous seeds. And the data compasses of the time period, the data that has been collected from 2017 to 2024. And the medical records have been evaluated for the demographic profile of the patient, which includes the age at presentation and also the gender of the patient, the laterality and the grouping according to the ICRB classification at presentation, the morphology of the vitreous seeds, intravitreal chemotherapeutic agents used, the total number of injections given per eye, and definitely the response to the therapy. The primary disease was treated with a minimum of 6 cycles of 3-weekly intravenous standard triple drug therapy that was given to the patient. And additionally, the focal laser thermotherapy and cryotherapy were also administered as and when indicated for the patient. The patient who had at least 3 months of follow-up from the last intravitreal injections were included in our study. So the primary outcomes of our study were the seed regression and the recurrence of the vitreous seeds post-intravitreal chemotherapy. The secondary outcomes guiding the study are the globe salvage rate and the ocular complications post-therapy. The age analysis showed that the mean age of presentation was 17.7 months, a range of 2 to 36 months. The mean follow-up was 23.5 months. Total 19 eyes were included in the study, which received 51 injections in all, with a mean of 2.7 injections given per eye. Coming to the vitreous seeds morphology, 14 eyes showed dust, 13 showed spear, and 5 showed clouds. Coming to the result of the study, the seed regression was seen in 16 out of 19 eyes, that was 84.2%, and time to seed regression was a mean of 1.2 months, a range of 0.6 to 3.2 months, while seed recurrence was seen in 3 eyes. The globe salvage was attained in 63.2% of the eyes. The complication of the intravitreal therapy noted were cataract, that was seen in 3 out of 19 eyes, and pigmentary retinopathy, that was documented in 2 eyes. I would like to summarize that the intravitreal chemotherapy with the melphalan or topotecan resulted in complete resolution in 84% of the treated eyes over a mean follow-up of 2 years. The globe salvage was 63%, with the complication rate being reasonably low. I would like to focus on that the more than half of the enucleated globe had recurrent tumor but regressed vitreous seeds. So I can conclude that the globe salvage may be impacted even after a good vitreous seed control has been attained. Thank you so much for your patient listening.
So you have the combination melphalan topotecan or only single drugs were used?
At a time, at one sitting we give single drug, but then we definitely, if we start with topotecan, we increase the dose or we switch to melphalan when the patient is not responding.
And all those cases, is it it's a adjuvant therapy or it was You have already primary systemic chemotherapy or intraocular chemotherapy was
Definitely. A
used?
primary systemic chemotherapy is given, but only when there are focal diffuse seeds which require treatment and they are recalcitrant to the systemic therapy, we go for the intravitreal therapy.
And what about the frequency after each interval? How many? After 2 weeks, 3 weeks? How do you?
3
go
weeks.
about it?
3 weeks.
Okay.
Thank you.
Next presenter is Dr. Nisha, and she will present retinoblastoma in a resolutely rare rendition. And I think she is also not the ratified member, as her membership number is 29571, more than.
Esteemed panel of judges and my dear friends, a very good evening. I'm Dr. Nisha Arpillai from Minto Ophthalmic Hospital, a junior resident, and I'm going to be presenting about a very rare case of retinoblastoma. Case of retinoblastoma in adults over the age of 20 are very few and far in between, and as per literature review, only 45 cases have been reported as of 2016. And the biggest challenge that we encounter in managing adult RB is coming at the right diagnosis. So, owing to the extreme rarity of this condition, it often remains undiagnosed or misdiagnosed, which in fact delays the treatment for a condition that requires immediate attention. So, two possible explanations have been cited for the development of adult RB, and there's either de novo, where it comes, there's a malignant transformation of embryonal retinal cells, or there's an oncogenic mutation of an otherwise quiescent or aborted RB or a pre-malignant lesion such as retinocytoma. So, a 26-year-old female from Mysore presented to us with complaints of pain, intermittent swelling, and loss of vision in the right eye since 3 years. In 2021, the patient was evaluated in Mysore and B scan was done, which showed features of vitreous hemorrhage and chronic RD. The CECT corroborated the findings, and similar symptoms also followed in 2023. And the patient was evaluated in a different center in Mysore, and CECT orbits were again repeated because clinically they were suspecting orbital cellulitis. And CECT showed features of retroorbital fat stranding and also right optic nerve thickening. The patient was managed conservatively for raised IOP and then referred to us for further evaluation and management. So this is the clinical profile of the patient. So the right eye, it was a PL negative eye with a ciliary staphyloma, and there was also a swelling in the inferotemporal aspect, the origin of which could not be made out. And the anterior chamber was filled with fibrinous exudates and also blood clots. The left eye was within normal limits, and this is a B scan image of the right eye. So since the patient was a case of painful blind eye and the diagnosis was still not known to us, enucleation was planned after obtaining informed consent, and the enucleated specimen was sent for histopathological evaluation. And the gross cut section showed grayish-white areas, and histopathology showed round blue cells with extensive areas of necrosis, and tumor was seen infiltrating the sclera as well, and even there was optic nerve involvement. Very few rosettes were seen, and a final diagnosis of high-grade, poorly differentiated RB was made. Immunohistochemistry was done, which was positive for synaptophysin and also neuron-specific enolase, which actually ratifies the diagnosis. And it was negative for chromogranin, desmin, LCA, and cytokeratin. All these are to exclude other differentials, which include lymphoma, leukemias, and also rhabdomyosarcoma. Ki67 was 80%, and genetic evaluation had actually shown that the patient was negative for RB1 gene mutation. So this is the image, and there's just, like, with a lot of difficulty, we found that rosette. Metastatic workup was done, and it was found to be within normal limits. The PET-CT and the MRI was normal, and bone marrow biopsy was also normal. The MRI brain showed no evidence of disease. The patient was started on standard dose chemotherapy, which was carboplatin, vincristine, and etoposide for 6 cycles, which was followed by 21 days of EBRT. The patient was classified as IRSS stage 2 or ICRB group E, and because of the high-risk features, the patient had been initiated on chemotherapy. And since the patient had no preservable residual vision, and with the diagnosis being uncertain, enucleation was the most suitable option available to us. And it also helped in formulating a histopathologically confirmed diagnosis, which played a very important role in this case to plan the rest of the treatment. And of course, long-term follow-up is very much necessary in this patient in order to detect metastasis or the involvement of the other eye. So the current classifications of RB are all restricted to pediatric populations, and hence its relevance with regards to adult RB still needs ratification. And in a case series by Zhu et al., which to my knowledge is the largest number of patients in a single case series, about 6 patients. So in that, 4 patients with ICRB-C and 2 patients with ICRB-D group had undergone lesser aggressive treatment approach in the form of transpupillary thermotherapy and also plaque brachytherapy and local resection. And only 1 patient in that ended up with enucleation, which shows great promise in globe salvage procedures provided the disease is identified earlier in its course. And a SEER-based population analysis using propensity score matching revealed that adult RB has worse survival than pediatric cases. So because of the multifarious presentations which are associated with retinoblastoma in adults, coming to a straightforward diagnosis is a very big challenge, and it is further convoluted by exceptional scarceness of this entity in adults and also other impediments in diagnosis because typical features such as calcifications are lacking. And therefore, high index of clinical suspicion is a must while dealing with such cases, especially painful blind eye, which is unexplained. And this underscores the very important need for adjunctive HPE. And multitudes of treatment options are available, which has to be tailor-made as per the patient profile. And the line of management also needs to be carefully sought out. So these are my references. Thank you.
Thank you. The last presenter is Dr. Shahar Rafat. She'll be talking on expression of steroidal coenzyme desaturase 1 in eyelid sebaceous gland carcinoma.
Good afternoon, everyone. I am Seher Rafat from All India Institute of Medical Sciences and going to present expression of steroid coenzyme A desaturase 1 SCD1 in eyelid sebaceous gland carcinomas. And these eyelid sebaceous gland carcinomas are the rare yet malignant, aggressive malignant with high risk of recurrence and metastasis. So it's a third most common cancer after the basal cell and squamous cell carcinomas and commonly found in the Asian population. So lipid metabolism is plays a very crucial role in tumor biology, and in various cancer it has been seen upregulated. So this is SCD1 is one of the key enzyme in the lipid metabolism, and it plays it's a catalytic enzyme which converts the saturated fatty acid into monosaturated fatty acids. These fatty acids and increased or upregulated SCD or lipid metabolism helps in the tumor cell growth, progression, metastasis, and even helps in resistance against the chemotherapies. So in this study, we are reporting the SCD1 expression in 39 sebaceous gland carcinomas patients by the help of IHC, real-time PCR, and Western blotting. Coming to the results, the mean age of the patient is 60 years, and the mean follow-up is around 38 months. So coming to the expression, overall the high XCD immunoexpressions done by the immunohistochemistry is higher in 33 cases, and high mRNA expression is found in 31 cases. Next 28 cases shows the both high SCD expression, protein expression by IHC, and high mRNA expression. And these 28 cases showed the strong concordance with both the levels, protein levels as well as the mRNA levels. There are the 6 recurrent cases and the 1 case of death having the high expression of both protein and mRNA, and there are the 15% of the cases having the metastasis, and 60% having the lymph node positivity cases having both the high expression of protein and mRNA. So this is the table which is showing all the clinico-pathological features, and there is also approximately 80 to 85% of the cases having the pagetoid spread, showing the high expression of SCD as well as SCD of protein as well as mRNA expression. It also have been observed that almost all the female patients have the high expression of both the protein and mRNA. Next, we analyzed the expression of these eyelid sebaceous gland carcinomas compared with the normal eyelids. And it is found statistically upregulated in all the eyelid sebaceous gland carcinomas. This is the Western blot protein expression showing the few of the representative cases from which we isolated the protein and did the Western blotting. And similar results were found like with which we observed in the IHC. So coming to the conclusion that there are more than 70% of the cases showing the high expression of both high protein as well as mRNA expression of SCD, and there is a very strong concordance between them at both the levels. Or also, we found that most of the cases, more than 50 to 60% of the cases, like metastasis, reoccurrence, and the lymph node positivity was found high SCD expression, and this shows they have associated with the aggressiveness of the cancer. So this plays a pathogenesis, could play a role in the pathogenesis and to help in identifying the high-risk patients. So we can also explore the potential it could act as a therapeutic potential for targeting and for the recurrent cases, chemotherapy-resistant cases in combination with the conventional chemotherapeutic agents, and could offer a new avenue for the management and to overcome the resistance and recurrence. Thank you.
Are you a member of the AIOS?
No.
I think with that we finish all the talks here, and I congratulate all the speakers. It was for the wonderful, bring up wonderful topics and then discussing over here. And yeah, for the final, this can you all come up, please, for the group photography. The results I know will be announced after some time, not now, but we have the group photograph.